Sandra all the time is here with the cold hard truth. She's the ears and the eyes for me and you. Every day, everyone want to hear from Sandra. And every time on the air, she's getting better. Tell your sister, tell your brother, tell your mama, call Sandra in the morning and in the evening. They always calling Sandra. And when they start fighting, they calling Sandra. And
That's right, folks. Everyone is telling their mama about the cold hard truth. Welcome to another episode with more truth telling, more problem solving, and of course, more tea spilling than ever before. Sit back, students, grab your tea and turn up the volume because class is now in session. Call in at 936-2626 because your voice matters. Share your opinion on issues that matter the most to you. Good morning, everyone. Hope that you guys are doing just fine. We are in the studio this morning. We've got some special guests who are going to be joining us. We are very, very pleased, obviously, to welcome them to the program. So we're going to go ahead and get started. Lots of ground to cover today. So let's start first with none other than Mr. Shamari Scott. Good morning, Shamari. How are you?
Good morning, Sandy. How are you doing?
Hi. Can you hear me okay, Shamari?
I can hear you. Can you hear me?
Uh-oh. You can hear me, but I can't hear you. Give me 1 second here. Let me just try to see what's going on. Oh, my goodness. I tested this last night. We're remote today, so I did test it last night, and we were all good.
Test. Can you hear me?
Right, Shamari. I said I should be able to hear you.
Can you hear me now? Can you hear me? I'm speaking. Right. Can you hear me?
I'm not hearing you, but I do see that you are most certainly speaking to me. So let's go ahead and bring in our guest in the meantime while I try to just sort out my audio just a tad here. Of course, I see that you're the only person here at the moment. Wait a minute. Oh boy, 1 second here, Shamari. Let's see what's going on.
Can you hear me now?
Okay. You know, you test these things and they work the night before. There we go. Let's try that again. All right, give me 1 quick second, Shamari. Just one.
No problem. No problem.
Gonna try to sort this out. All right, let's try that again. Good morning to Mr. Shamari.
Good morning, Sandy. How are you doing? Can you hear me?
There we go. Yes, I can hear that wonderful voice of yours now.
Amazing.
Thank you so much. Yes, I'm like, hey, I tested this last night. Something's going on here. A little
No
gremlin in the
problem.
speakers.
No problem. No problem. I see Dr. Cyril.
You see him?
He's popping on to a Teams meeting that says, so I don't know if
I know the doctors are busy.
No, he's popping on to I think, when you schedule the time in Teams, sometimes it shows up as an actual meeting, and I think he's logging into that versus the actual link. So let me try and message him to tell him.
No worries. We'll, in the meantime, we will say good morning to everyone while you're sorting that out. So good morning to Keel, who's joining us from Raleigh, North Carolina. He says happy Friday Eve to everyone. Marshall is in the studio. Good morning. Well, not in the studio, but he's in class. Good morning to Marshall. Good morning to Miss Brenda. How are you? Wee has got it locked. By the way, folks, I know I keep saying Bobo 89.1. It's actually now Bobo 103.1. So there has been a change in the frequency. And so they're working on that. So stay tuned, folks, for that. Hopefully we'll be able to get that on a regular here in terms of remembering to say it. So it's now 103.1. Yeah, pretty cool. So I think they're just aligning all of the frequencies to match where they should be matching and that sort of stuff. So it's all good. And I definitely want to let you guys know. I think that at the end of March, it will be swapping over. So for now, you can hear the station on both frequencies, but then the end of March, it's actually going to swap over to just 103.1. So you might as well just dial in 103.1 from now on your frequency, right? All right, and I am sending the link out to everyone as well. So I'm not in the usual studio today. I am remote, so to speak. So hopefully we'll be able to have a seamless show regardless. Thank goodness for the technology that we have available to us that allows us to accommodate these types of scenarios. So yeah, sometimes you just can't be in your regular spot, which means FYI that you can't actually call in today either because we don't have the phone available. So let me just tell you guys that, but you can certainly WhatsApp us and we will read your messages if you would like to share any thoughts or comments or questions with our guests this morning. All right, beautiful. Very good. So we've got Barbara and Miss Dawn in class as well. Patricia Blake is here. Good morning to Miss Patricia. How are you? She said, happy Wednesday. You missed the day, honey child. It's not Wednesday. It's now Thursday or Friday part 1. So I know yesterday was Ash Wednesday. And as you guys know, we celebrate Ash Wednesday in the Cayman Islands as a holiday, as a proper holiday. So yes, you guys hopefully enjoyed it yesterday. I think that quite a few people were able to make it to the annual agriculture show. We've got Miss Jean joining us. Miss Nighty, hello. Not on radio. Uh-oh. We should be. I'll play around with that and see what's going on there. And give me 1 second then. So if we're not in radio, that means that I need to play a little bit of something to pop us back in. So give me 1 quick second. Miss Nighty, just confirm when you're hearing it on the radio station for me. folks. Hopefully, we can get kicked back on this morning. I don't think that worked actually, but I have messaged the studio to get someone to manually do it for me. But listen, we got to enjoy a little bit of our national song while we were at it. So it's all good. It's all good. All right, Shamari. Good morning
Good
again,
morning.
and
Good morning.
for joining us. Yes, we've got Dr. Cyril, who's going to be joining us as well. So let's go ahead and welcome him to the studio. Good morning, Doc. How are you?
Morning. I'm good. I'm good. How are you doing?
Yes, I'm doing very, very well. Thank you so much. So nice to see you here today. And of course, we're going to be talking about a very, very important topic. All of your topics are important, but I feel like this one, personally, recently we've known a friend who was diagnosed with colon cancer, stage 4. And so this is something that I have been talking about, even my journey from last year when I did my first colonoscopy, just really, really encouraging people to educate themselves on this topic. And I'm so glad that you guys are covering this today, because we need reminders of why it's important to know about colon cancer, to know about your colon health, and what some of the things are that you need to be looking out for. So, Shamari, I know Dr. Cyril has been on the program before, but for those guests who may not have heard him, please
Definitely.
do the honors of introducing him for us.
Definitely. So Dr. Cyril Alex has been with us for approximately 3 years, but he has a lot of experience. He's our consultant gastroenterologist. He's done over 7,000 endoscopic procedures, over 5,000 colonoscopies, which we'll be discussing today. He specializes in advanced endoscopic procedures, bariatric procedures, and management of complex gastrointestinal conditions as well. So that's the brief overview, so that we can get into the meat of the matter. But as you said, this is very important, especially to our Caribbean men of everyone, but Caribbean men of Afro descent. Just because the guidelines would tell us that we need to be getting colonoscopies a little bit earlier. And I know a lot of us that there's a stigma attached to it, so many of us don't go get it. And unfortunately, I was actually sharing a video that you will see shortly. And a good friend of mine mentioned that his father actually passed, and it was due to the fact that he actually didn't go and get the screening, and it was actually colon cancer. That took his life earlier than it should have been. So,
Oh, wow.
go through today. Definitely want to convince as many to definitely go ahead with the screening and the procedure to make sure that we can check and make sure everything is okay. And if it isn't, and we catch it early, as we always say, early detection is always best, because then that gives you significantly increased better outcomes and life as well.
Yes, absolutely. And, quite frankly, this is something that is impacting not just, people of African descent, Shamari, but the
Correct.
guidelines, Dr. Cyril can tell us about this, that now we know that probably because of our lifestyle and diets and so on, that the age, generally speaking, has been adjusted down to 45. Is that right, Dr. Cyril?
Absolutely, absolutely right. The age has been brought down to 45. The reason was, earlier we were, we will go that into the detail later, but, earlier we were, screening everyone above 50, and the incidence of colon cancer mortality in that age group started coming down. Then we noticed a rise up in the 40 to 50 age group, especially in the, Afro Caribbean descent. There is definitely a high incidence in that group. So that's the reason why they brought it down to 45. Like how you said, 45 is the current cutoff for starting screening.
Yes, well, most certainly, it's one of those things where we've got to be educated about it. I mean, that's the first thing, and that's obviously why we're here today, to really ensure that everyone is aware of their associated risk, and of course, just to make sure that you have all of the available information about what it is that you need to do. So, Dr. Cyril, let's talk about what the colon is, first of all, and then we'll get into some of the details.
The colon is basically the the last part of our digestive tract. Mostly, the major function is absorption of water. Then it stores as the stool, sort of a reservoir where the stool transits out slowly. So this is a site of colon cancer, or the large bowel cancer. And colon cancer is one of the commonest cancers. In males, the third commonest, and in females after breast, the second commonest. Worldwide. It's and there's some peculiarities with respect to colon cancer, in the sense that it's
Mm-hmm.
most of the colon cancer starts off as polyps. And they take a lot of time. In fact, some of the studies mention around 5 to 15 years before they turn cancerous.
Mm-hmm.
So we have a long window period wherein, if we take out these polyps, then we can in effect
Mm-hmm.
prevent the colon cancer from developing. That is
Mm-hmm.
the the advantage. There are very few cancers, maybe cervical cancer, wherein we can pick it up and stop it before it turns cancer. Unlike most of the other
Mm-hmm.
cancers which we know about. We identify most of the other cancers when they become cancer. Here we have
Mm-hmm.
a cancer wherein we get a window period wherein we take out the polyp, we remove it before it actually turns cancerous. Okay, yeah, yeah.
Mm-hmm.
That is why, one, for instituting any screening modality for any cancer, it should be
Mm-hmm.
widely in spread cancer. It's a cancer which is prominent in the community. Yes, that
Mm-hmm.
colon cancer is, like how I said, almost second or the third known cancers. Largest cancer, the colon cancer being. The second is, we have a window period of almost 10 years, 15 years, wherein we can detect the cancer and remove it or prevent it from forming. And we have good easy modalities to find these and detect these, being colonoscopies, stool tests, the various modalities which we'll discuss later. So that is why the colon cancer is like a preventable cancer.
Mm-hmm.
Okay.
Mm-hmm.
Yeah.
Mm. Very good to hear. So preventable, folks, what that means is, as long as you get ahead of it in time, is something that you can actually, do something about. So we know that there's certain risk factors, Doc, and we see on the screen now, for those who are watching on social, that some of the risk factors we can have a lot of control over. There's one on here that there's been a lot of discussion around lately, and it has to do with alcohol consumption. Now, I have been kind of watching the health news recently, and I'm astonished that it's only now that we're looking at, this side of alcohol, but really and truly, the data is showing that alcohol is contributing to a lot of things and a lot of cancers. And of course, having just seen this in the last couple months, even last year, I'm not surprised to see that it's on this list of risk factors. So we've got age, family history, obesity, a poor diet, alcohol, a history of inflammatory bowel disease, and then this one came in as a little bit of a shocker: type 2 diabetes. So let's dive into some of these risk factors a little bit here.
So yeah, the age, the traditionally, age, the family history,
Mm-hmm.
definitely. So one of the common misconception which people usually, I get colon cancer only if I have a family history. If
Mm-hmm.
you take all the colon cancers, only around 15 to 20% actually have a family history. Definitely, when
Mm-hmm.
you have a family history, you are definitely at a 2 to 3 fold, higher risk of colon cancer, no doubt about it. But
Right.
the other 80% are what we call as sporadic, wherein
Yes.
you don't have a family history of colon cancer. You
Mm-hmm.
develop it out of the blue, that sort of a thing. So that is another reason. Then
Mm-hmm.
definitely diet, obesity, are known to have So this is another little controversial. In all the papers, if you read, red meat, you will see, high fat red meat. Definitely red meat based on a if you on a larger nationwide program as well. If you try to cut off red meat, when you come to the individual level, yeah, by the time these polyps develop, you're at 50, 55. The it has to start much more earlier, rather than because there are various studies which have been conducted. Definitely red meat has been shown to have a definite link. One of the shown to be like a two-way carcinogen, in fact. But the problem with a little controversial, but even when people come to us before, we used to say, okay, cut off red meat, cut off, include a lot of fibers. But once these polyps develop, uh, it as at an individual level, it doesn't make a dramatic difference. Yeah, on a nation, on a population study, yes, definitely. But at an individual level, I know it's a little controversial for me to say that. The thing is, there have been studies wherein they've tried like a chemo prevention policy. They have given certain groups a lot of fibers, cut off red meat, and the other group, in those people who had polyps detected at the first colonoscopy. When they repeated the colonoscopy, almost the same incident. So the fact is, we have to start much more before, much more earlier, and rather than once we develop polyps, we cut off, red meat. Another study had done at Oxford, with vegans versus, who consume red meat. 10 years long study, almost 2,000 people, almost the same incidence of colon, yeah. So all these do, play an important role. Definitely, no doubt. Obesity, definitely age, diabetes along with obesity, that sort of a thing, not like a definite, but definitely inflammatory bowel disease, smoking, I think we discussed last time about inflammatory bowel disease, wherein the colon has inflammation. It is definitely a a higher risk, and an increased risk for colon cancer. As a population, as a nation, we have to definitely cut down on the red meat, on an earlier, rather than when things are at 50, 55, like I said, it takes almost 5 to 15 years for a polyp to transfer into a colon cancer in a normal average, person. So for a polyp to develop, it takes almost that time, and all the inciting factors to add on to, for that polyp to develop, it takes much more longer. Yeah. But definitely, yes, moderation in all these things, yeah.
All right. So
Sandy,
yes,
I was about to say that you look like you're in a familiar house. Because there is one colleague that's always in that house.
I know. We're sharing the mansion today. Yeah, they've got to give us more backdrop options, man, because it's hard to convince people that that's my grand piano in the background over there when everybody uses the same one. So yes, I mean it's very, very interesting what you've said about the contributions to diet, and of course, I'm sure as parents we're sitting here listening to this because now if we're saying the age has dropped to 45, earlier screening. There's some instances of even younger people in their early 20s being diagnosed with advanced stage colon cancer, which is, at one time was more or less unheard of. That really means that the diet of our children undoubtedly has changed dramatically and not for the better. So you talk about these dietary impacts and influences really starting earlier on. Wow, it seems to me that probably childhood obesity and these other dietary things could be a very serious contributing factor as well. So, Dr. Cyril, it's definitely food for thought, quite literally.
Definitely, yeah. Genetics definitely do play a role, some of these, there are syndromes where we have to be, but like I said, 80%, sporadic, without family history and all those things. Yeah.
Right. And when it comes to the alcohol now, what is it about that you think might be specifically contributing?
very difficult. It's a very gray area. Like I said,
Mhm.
alcohol. So I'll tell you, most of these studies, how they are, done is they we they do it on people who have colon cancer, and
Mhm.
when we ask them, were you having alcohol? Yes. Were you having consuming excessive red meat?
Mhm.
Yes. You are in that. You're trying to figure out why I got this disease. So,
Mhm.
yes, there is always a recall bias, but
Mhm.
definitely some animal studies are coming up wherein they're fed fat, the alcohol, and the inflammation, leading to colon inflammation.
Mhm.
But I wouldn't definitely go into that this is the only reason
Mhm.
or anything like that. Definitely a completely
Yes.
different, yeah.
Yeah. And then type 2 diabetes. Interesting.
Part of the obesity spectrum,
Mhm.
the diet,
Yes.
the fat, that spectrum of obesity, smoking,
Yes.
the lifestyle, basically it
Yeah.
comes into that. Again, a very soft few studies showing plus.
Mhm.
Yes, definitely,
Yeah. All right. And I know that we've had you guys in the program here before talking about this IBD, inflammatory bowel disease,
yeah.
which
Yes.
is different. Some people confuse it with IBS, but it's
Yeah.
actually two very different things.
Yes, yeah, exactly. Like, like how we discussed last time, IBS means when we go inside, the colon is clean.
Mm-hmm.
Inflammatory bowel disease, a lot of ulcerations, inflammation,
Mm-hmm.
redness, bleeding, that cycle, they are at a higher risk for colon cancer because all these inflammation healing back and forth
Mm-hmm.
induces certain changes. So after
Right.
7 years, 8 years of IBD, they are definitely at a higher risk, and we put them on a screening, irrespective
Mm-hmm.
of the age. After 7 to 8 years, they, and then we follow them up.
Mm-hmm.
Yeah, yeah.
Hmm. All right, we've got a question from Ellard. Ellard says, does Health City do any colonoscopies where the patient is awake, like other overseas hospitals offer? And why is this way sometimes preferred? This allows the patient to see the camera, the screen, and their colon in real time as well. Is it necessary for patients to be viewing that, Dr. Cyril?
No, so that's a good question. In fact, most of the colonoscopies which were done before were, under either just a small sedation wherein they are awake. What we found was we have to inflate air in the colon to, see all these areas folds properly. Okay. Each colon is different. Some colon too much torches, too much, the pain sensitivity of each of us is different. And the main pain sensitive thing in our colon is the stretch. The moment we put in air, the stretch induces cramps. When how we feel when we are not able to pass gas or wind, you feel. So the main pain sensitive thing in the colon is the stretch. So what we realized was the that's why colonoscopy got a bad name. In fact, some of them come out crying, paining, the whole experience was really bad. We can still do colonoscopies, that's how we used to do
Mm-hmm.
colonoscopies before, where they are awake, they can see. But sometimes when the colon is little tortuous, difficult, tight bends, when we manipulate the scope, put in air, a lot of cramps, discomfort, sometimes because of the pain, the patients themselves say, doc, done, I can't tolerate it furthermore. And then the pain induces changes in the heart rate, cardiac, sweating, syncope,
Mm-hmm.
all these things, much more preventable, both comfortable for the patient as well as the doctor and the entire team.
Mm-hmm.
We record the entire video, we take in the pictures, we come back,
Mm-hmm.
and show them the pictures and all those things. But definitely we can always do it, without sedation. Yes, definitely.
Yes. I can't imagine anybody, let me just say this, as someone who's done it, I can't imagine anyone wanting to do it without sedation. I've heard of a few people who have tried that and then they've had both. And, they always say, I don't know what I was thinking, trying to do it without sedation. It made zero sense. So don't make this uncomfortable for yourself because, of course, that is one of the fears of the whole situation that, oh, you're gonna have pain, you're gonna have, listen, when they sedate you, Dr. Cyril obviously did my procedure. It's a procedure that you're not gonna remember, you're not gonna have any memories about, and that is exactly how you want it. You want to, wake up and everything's fine, and he's gonna give you some good news. Dr. Cyril, thank you so much too for the way that you guys do the procedure. I found that there were so many checks and balances, like going into it. Consultation before with Dr. Cyril, where he explains everything that you can expect, so there are no surprises. And he also explains that, listen, if we find anything, we're going to remove it right away. We don't waste any time. If we find any polyps, we will remove them, send them off to the lab for testing and so on. And as he indicated, pretty much as you're done with the procedure, they're able to tell you immediately what they saw, and they'll give you all of that information in terms of the photos and everything as well. So we'll talk a little bit more about the actual procedure here, because I think people have a lot of fear around it when they really shouldn't. From my own experience, I must tell you, I was a little bit skeptical myself, but having gone through it, I can tell you there's nothing to fear. So symptoms, and of course the symptoms we're talking about here is whenever you already have colon cancer. So are there no symptoms before it turns into cancer? Like at the polyp stage, you wouldn't even know. That's
a sad part. By the time, we get all these symptoms, they are, most likely a large sized established cancer. And the interesting fact is, if you are able to detect this cancer at the polyp stage or the early cancer stage, the 5-year survival is more than 90%. And the moment it goes to, established cancer, lymph node, mets, it drops down to, 20%, 30%, some study, it drops down below that. So that is the whole, thing of detecting the early, even when you're asymptomatic. So, by the time you get bleeding, the obstructed state, it has already turned cancerous. It has grown in that much size to occlude your large bowel. Yeah. Then by the time you have weight loss, means that cancer has spread. So we are not doing all. We want to detect all these things in an earlier stage, wherein 5-year survival more than 90%, 95%. You take out the tumor at that stage, done, so that you go back to your normal life.
Right.
So.
All right. So some of the symptoms, though, you could certainly be looking out for a persistent change in your bowel habits, including diarrhea or constipation, or a change in the consistency of your stool. So this is one thing that a lot of people don't think about, but you should be looking at your stool, right, Dr. Cyril?
Not that often, but definitely, you should be looking for blood, as well as, any sudden change, some, especially after a particular age, you were always clockwork with your bowel, every day morning, suddenly you're seeing that the caliber is changed, you're not passing, suddenly a few days of diarrhea, little blood traces here and there, little cramps, you were always, you never had any pain. Now you have started having a new onset of pain the moment you want to pass stools, or the moment you have some food, you have an urge to pass with a cramp, pain. All these are soft signs wherein you look for lesions. Like how you said before, age now has come down definitely. So any bleeding, especially in a younger age group, persistent cramps, definitely worthwhile. Any anemia, any low blood levels in someone who is 50, 60, that's a peak time wherein with the colon cancer is picked up. So you check it out. Another fallacy is always any bleeding, we take it as hemorrhoids or piles, or a cut in that area, and then we tend to neglect it. But yeah, any bleeding, any weight loss, anything new, your body well, you know how it works. So some people, constipation might be, they are always constipated. We're not trying. That's how it has been for the last 20 years. But we're talking about something new which has come in, some dramatic change. Then you check it out.
Yes. All right. So Mellow Fellow has a question. She says, good morning, CMR and the HCCI team. Please explain the difference between a colonography and a colonoscopy, and when one is used versus the other.
I believe the. I mean, I could not see the question really, but it.
Yes.
I believe it's a CT colonography. CT colonography is, I believe, what the viewer is describing and
Mm-hmm.
asking about. It is one modality. So how the societies classify is they classify all these modalities into different classes tiers. So the first
Mm-hmm.
tier, colonoscopy, animal stool test. Then you have the CT colonography based on sensitivity. So you take the prep as before,
Mm-hmm.
and you do a CT scan, okay, every 5 years,
Mm-hmm.
okay. What are the okay thing? Anything bigger than a centimeter or so, almost good sensitivity to pick it up. Any flat lesions, anything smaller than that, the sensitivity starts coming down. And if you find anything, you go back to doing a colonoscopy and
Mm-hmm.
taking it out, removing. So some people who are
Mm-hmm.
very reluctant, elderly, who have got a lot of comorbidity, whom we don't want to do a colonoscopy, put under anesthesia or anything like that,
Mm-hmm.
we can do a CT colonography. Give the prep. They have to take the prep.
Mm-hmm.
Uh, there are few investigative wherein they tried avoiding, but still, for the time being, you have to take
Mm-hmm.
prep and get a CT scan done every 5 years.
Mm-hmm.
Anything above centimeter or so, good, okay sensitivity, almost comparable to colonoscopy. But anything under than the flat ones, then you have to, there is a miss rate, but you definitely can do colonoscopy, CT colonography. The colonoscopy is directly visualizing the inside of the colon with the camera, and we take
Mm-hmm.
biopsies, remove the polyp. 95 to 96, most of the polyps we try to take them out the same time, unless they are really big, wherein it's going to take a lot of time. We have to come back and talk to you. This is a big
Mm-hmm.
one. We have to take. You have to. No, otherwise, most of the polyps we take them out the same time.
Mm-hmm.
So that's the primary difference between a CT colonography and a colonoscopy. One, every 5 years, you get a CT scan done. If anything abnormal in that, you do a colonoscopy. Other one,
Mm-hmm.
the colonoscopy for an average risk, nothing to be found, less than 1, 2 polyps, you do it every 10 years.
So that's very, very interesting. Um, and yeah, I mean, and I see what you're saying. So with the colonoscopy, you always have the opportunity normally to take it, remove most of them. And so
Yes.
that's the benefit of, because of course, if you do the CT scan and you find something, then you have to turn around and do a colonoscopy anyway.
Yes.
Yeah.
Yes,
Okay.
absolutely right. Yeah.
All right. So very, very good. So some very good questions here. Everybody's paying attention this morning. Selvin has an adult question for you. I'll let you read it. He's just saying if there's certain types of sexual activity in that area that might contribute to cancer as well.
Yes, yes, definitely. There has been association with anal cancer.
Mhm.
With anal sex. Definitely yes.
All right. All right. So there are different stages of colon cancer. So when we're looking at the stages now, of course, that determines what sort of treatment options you have available. So let's go through these, Dr. Cyril. So you've got stage 0, and that's where the cancer has not grown beyond the lining of the colon, and surgery can be done to remove the polyp. So is that normally when you go in and you cut them out right away? Is that would be stage 0?
Yeah, usually the early cancer, early polyp and a high grade dysplasia, sometimes early cancers, sometimes even when they are around 1 centimeter, 2 centimeter, with small cancer cells in between, we can easily take them out. Not easy, but we can take them out during the same endoscopy without anything major going
Mhm.
on. So any cancer which is limited to that area, mucosa, submucosa area, that
Mhm.
is early stages. Yeah. Yeah.
Mhm.
Uh,
And I know that when I had my procedure, you said, "Oh, we saw a few polyps there. We took them out, but they're not the ones that lead to cancer." So tell us what does that mean? So you can
okay.
have other polyps.
Yeah, yeah. So the usual polyps which have a malignant potential, which has a tendency to for growth, is the type
Mhm.
called as the adenoma, the
Mhm.
tubulovillous adenomas. Those are the type of polyps which we're looking for. But there are certain polyps, they look similar, but on biopsy they will come as, hyperplastic, inflammatory polyps. All these polyps are, though they look like polyps, they don't have any, major, growth potential. So we routinely see them on the left side near rectum, the last portion of the colon. We see small hyperplastic polyps and all those things. Yeah, those are don't. So we don't put them on a, surveillance, or call them early when if we find such polyps. But the adenomas, the serrated polyps, the tubulovillus, the villus, these are different types of, histologically different types of polyps, which have different, growth rates, different tendency for cancer. So that's
Yes.
the primary difference between the ones which have the potential to grow and, without.
Yes. And a lot of times it's important to have, experts such as yourself with this experience, because my understanding is cancerous cells look different. And they do different things, even visually. Breast cancer cells, of course, you would always send these things to have them biopsied to ensure. But a lot of times visually, you can look at the edges in terms of how it's shaped and how it's organized. And so there's a lot with your years of experience that you can look at, even during that initial stage of having a colonoscopy done, that kind of what's going on, right?
True. Yeah, we do get a idea. So especially there are special imagings we use sometimes when we see such abnormal, looking at how the surface pattern is, whether there is ulcerations. All those indicate either a high grade dysplasia or a cancer which could be harboring in it. In such cases, instead of just cutting it off from the surface, we go inflate it up, lift it up. We try to cut the base and take it out entirely. Just because superficially cutting, you harbor the roots down, which will grow. Definitely yes, we do get an idea, not 100% idea, but definitely we do get a sense. Yeah.
All right, then we've got stage 1 cancer, which is the cancer has grown deeper into the layers of the colon wall, but it hasn't spread outside, and surgery to remove the polyps or section of the colon is normally the treatment method for that.
Yeah. So these are all, the progression, from the wall, the next level, the next stage, it starts going into the other loads without, some nodes involved. Then, the next stage, you grow to the liver, spread to the other organs. So basically different stages, wherein we primarily want to catch it at that stage 0, stage 1. That's that's what we want. But even if it is diagnosed, surgery, the chemo, sometimes in rectal this thing, they might give a radiation and all those things. Yes. So that's the in general broad plan of treatment of colon cancers.
Yes. And then we've got stage 2, where the cancer has actually gone through the wall of the colon and maybe into nearby tissue, but has not spread to the lymph nodes. In that case, it's surgery to remove part of the colon that contains the cancer, partial colectomy.
They remove part of the colon, just that sort of a thing. Yeah. So we the moment we diagnose, we have a multi-tumor discussion with the surgeon, the oncologist, the oncosurgeon, and decide what best suits for the patient. The staging, further staging is needed. Then we plan the treatment. Like I said, this is a broad general outline. Yeah.
Okay. Can you live without your colon? Is that
like I said, the primary function of the colon is absorption of around a liter of fluid. Yes, you can live without your colon. Yeah. So primarily that is most of the absorptive function of the nutrients, your protein, the all those things happen in the small bowel. So without small bowel, you can't. You are dependent on intravenous nutrition, but without a colon, definitely no.
All right, so our students are paying attention. Rennie has a question. Rennie says, is there any disadvantage to removing polyps that are non-cancerous? And why are those non-cancerous polyps there? So any disadvantages to removing those?
Nothing,
Yeah.
they're not actually meant to be there. It's like,
Yeah.
for sometimes, people ask me, how does the polyp look? I just point them to, what, or a skin tag.
Mhm.
It just looks like that. So
Mhm.
it is not meant to be there, except, unless you are creating a problem while cutting and removing. Most of these small
Mhm.
polyps, you just have to pick it out or cut it.
Mhm.
They don't
I
usually create
wonder. I wonder
problems.
if yes, my apologies. I wonder if
Sorry.
Reddy's thinking there was this old, like in communities like ours, sort of this old myths or whatever, where people say, "Oh, if you have cancer, don't cut it because when you cut it, it spreads." Is that true about cancers, generally speaking?
Um, I don't think so. Cut it in the
Yeah.
sense that there is definitely, I believe the misconception would have come from, there is something called as a needle track, transmission. We try to FNA something, put a needle inside. There is always a risk of a tract of, the tumor seeding out through that, tumor seeding out of the tract of the needle which you're putting it, around 3 to 4% maximum, but
Mhm.
nothing, it's not like how it is in colon. You have,
Mhm.
if you can remove it as a entirety, that is the best form.
Mhm.
But if you think that it has gone into deeper layers, wherein,
Mhm.
we can't lift up the colon, the polyp or anything, we
Mhm.
feel that it has gone to deeper, then you don't cut and remove it. Then you go for a proper surgery, rather than trying to remove it endoscopically. So definitely for the polyps, we, when we
Mhm.
do it, we inject it, we see it, we feel it, we see how it is adhered to the lower, inside the deeper layers. If we feel
Mhm.
that it is adhered, it has gone into the muscles, then that's not the stage wherein you
Mhm.
cut it endoscopically. Then you have to take it out surgically. But definitely taking out the tumor definitely is the treatment.
Mhm. All right. And then by the time you get to stage three, obviously it's much more serious. It has then spread to the lymph nodes, but not any other parts of the body, and surgery to remove the infected section of the colon, including the nearby lymph nodes, along with chemotherapy being the standard treatment at stage three. And then stage four, where it has spread from the colon to organs such as liver, tissue, as well as other places like the lungs, the brains. So how does cancer go from the colon to your lungs? That means that it's traveling through the bloodstream?
Yes, through the liver, from the liver to the
Mhm.
lungs. It's a bloodstream hematogenous spread,
Right.
most of the time.
Wow.
So yes, yeah.
Hmm. And of course, stage four then would be considered quite serious. Um, yeah.
But definitely, with all the newer chemotherapeutic agents, the
Hmm.
oncology medications, the
Hmm.
the survival, the 5 year survival definitely has improved. That is
Hmm.
why if you look at the data over the last 50 to 80 years,
Hmm.
the survival rate has gone up by, definitely 20-30% increase in the survival rate over
Hmm.
those year period. Mainly, even one, early detection, definitely. Then even if
Hmm.
they are when the treatment advances, the oncological medications, the
Hmm.
chemotherapy regimen, the newer radiation techniques, all those things definitely, yeah, has
Make a
improved.
difference. Very good. Sydney has a question. Sydney says, "Good morning. What causes the colon cancer to reoccur as much as 3 times in years?" So I wonder if he means colon cancer. Just clarify for me, Sydney, or the polyps. Because if you've got colon cancer and you go through a full treatment, depending obviously on the stage, a reoccurrence, I guess, is always a possibility.
Yeah.
Hmm. All
Definitely.
right.
So if it is the polyp, like I mentioned in the last study, even, they did a colonoscopy, they noted a polyp. They grouped people with high fiber, low, red meat diet, and the other group, but recurrence was almost same. Genetics
Yes.
definitely, all the things which have gone through your system, the
Mhm.
abnormalities, genetics, age, the main,
Mhm.
you can't get away with that. And
Yes.
other risk factors are still there. you know
Mhm.
so all these develop, keep on points. That's why the first colonoscopy is very important. I always tell my most of my
Mhm.
patients, because if that colonoscopy shows that you are, you're having more than 8 or 10 polyps, we know that you have to be kept at a closer follow-up. So it's not 10 years. We keep you, 3 years, so that we detect it much more earlier. Any polyp developing, anything grow, we just do them at the same time.
Yes.
And that is the importance of the first colonoscopy. It sort of risk stratifies you into a average risk or someone who we should put you in a surveillance program, where in 3 years, 1 year, 5 year, depends upon what we find in the first colonoscopy. Yes.
Very good. So we do have a video here that we're going to watch as well. So the standard protocol is if you do your first baseline colonoscopy and everything is fine, you don't have to do another one for 10 years.
Unless you have a family history of any high risk, thing like an inflammatory bowel disease or, otherwise, no. For an average risk wherein you don't have any family history, you don't have any personal history of colon cancer, IBD, anything, no symptoms, you don't do anything for the next 10 years.
Okay, very good. All right, let's have a look at this video this morning as well. So we know that Health City Cayman Islands has, amazing patients all over the world that come and have procedures done, and they have a lot of interesting testimonials that they oftentimes share. And it's very, very interesting to see how people have relied on the expertise and the services at Health City Cayman Islands. So let's have a look at this.
I'm 50 years old, born in Australia, but I've lived here in Cayman for half of my life. And yesterday, I had a colonoscopy.
I'm Tim, also born in Australia, but I've lived here for half of my life. Not quite 50, but I had a colonoscopy yesterday too.
And how did that go for you, Tim?
We've heard horror stories, quite frankly. We had one friend who did it, brought another friend along and discovered that there was something cancerous that they cut out, so he was saved by it. So it just made sense. These are always the worst attire of anything, trying to figure out how to actually put these things on. I was more nervous when they were putting the ECG on me to check. I feel good. I feel really good. No problems at all.
So this was your colonoscopy report.
Mm-hmm.
Yeah. Good.
Okay. As clean as a whistle.
Clean as a vessel. And nothing for you to worry about.
Yep.
Okay. Yeah. So nothing for you, you to do anything different until unless you have some new symptoms or anything happening new. You don't need to do another colonoscopy for the next 10 years.
Right.
Okay? Yeah. So see you. Thank you.
See you in 10 years.
A little nervous, probably. My first one. So I hope I've done everything right to get here.
Yeah. Right. Please.
It's going to be a very short procedure.
Okay.
We are looking at 20 minutes or so. You'll pick up to as nights, light sedation. What we want is you should not feel any pain or any discomfort.
Good.
And we're doing the colonoscopy, 20 minutes maximum. If there are polyps or anything significant for me to take out, I'll take a little more time.
Okay.
Otherwise, 20 minutes. You'll be out here in the recovery. Another 10 minutes, you should be fully awake. This is the right side of the colon. Okay, left side. Your prep was good. Small, nothing to worry about. No polyps. So nothing to be done for the next 10 years unless you develop something new.
Okay.
Okay.
Easy. Thank you very much.
Any pain? Any discomfort? Nothing. You're fine. Absolutely.
No, all good. Yeah.
Good. Yeah.
All right.
See you in
thank
10
very
years.
much. Yeah, no worries. So for two Australian guys who view this sort of thing probably not dissimilar to Caribbean guys, having something go the opposite end up the rear was a little weird to think about, and we did some mental gymnastics, I think, to get our heads around it.
So, what do you think the worst part of it was?
I think thinking about it
Mm-hmm.
and worrying about it, everyone says the prep is bad, but
Yep.
I actually didn't find that bad at all. I mean, I've never gone to the toilet in such volume before,
No.
but it was fine. I mean, it kicked in fast. We spoke about this yesterday morning. Like, before it even finished the first one, like, oh, I'm upstairs, gotta go. And then it, yeah, I mean, we don't need to get too graphic, but it all came out pretty fast.
Yeah. So, no, I agree. The one bit of good advice I did have was get wet wipes. Made things a lot more tender.
That's some of those as well.
It was a little tender. That was the worst part. But you're right. I was worried that I would be starving, that the fasting
Yeah.
was bad, and that part would be bad. But apparently, well, sitting on the, I guess we've got lots of practice sitting on the loo reading, escaping the family. But no, that wasn't bad at all. It was just the tenderness, but not a problem. Yeah.
I agree. Wet wipes are king.
So I'm glad we did it. I didn't realize that colon cancer was one of the most prevalent cancers in Cayman Islands.
This month is Colon Cancer Awareness Month, so from a community spirit point of view, I'm glad we did it.
It was easy to do.
For it.
Yep.
And now we know.
Now we
10
know.
years, clear as button.
Yep, 10 years in the clear. If you meet the criteria, you should definitely go and get tested. It's quick, it's easy, and it's just worth doing.
So let's break the stigma for something that's so easy to do. Let's go get tested and put an end to colon cancer.
All right. So, you know, as they have said, relatively easy to do. It wasn't anything that was particularly difficult. And so, yeah, you know, it's prevention certainly is the key here, and early detection. So Danny's asking, what is cancer?
Cancer is any abnormal tissue proliferation, uncontrolled abnormal tissue proliferation. Means normally every cell in our body goes to a cycle wherein, you know, it has to, you know, regenerate, then it dies, you know. Here we have a group of cells which go out of control of body's control. Or, you know, there is a control system wherein it has to divide into only this much. After this many cycles, it should die. You know, that control is lost. You have an uncontrolled proliferation, multiplication of the cells, and it goes out of the control of body's mechanisms. That is cancer. So any growth, you know, so it eventually grows. You know that.
Yes. All right. And there are things that you can do to help prevent colon cancer. Lifestyle changes certainly are important. You know, if you have a genetic predisposition, you want to make sure that you're doing these earlier and more frequently, and, you know, consulting with Dr. Cyril to ensure that you're getting adequate testing. But everything from increasing your physical activity, and, you know, these things every single time we do, whether it's breast cancer, colon cancer, any kind of cancer, and just overall wellness, it's amazing how the exact same things always show up on the list, folks. So this is going to help you not just in terms of colon health, but just overall health and wellness. So these things are important. You know, increasing physical activity, maintaining a healthy weight, eating a diet that's low in animal fats and high in fruits, vegetables and whole greens. Limit your alcohol consumption. If you can do without it, maybe consider that as an option. Avoid tobacco completely, because there's no good side to tobacco either. And then, of course, the vapes now, Dr. Cyril, they seem to be all the rage. They're no better for you, we've discovered. So don't do that either. And then some general screening guidelines now, which in the last couple of years have been adjusted, including the earlier age now of 45. So begin screening for someone who has an average risk of colon cancer. They should now begin screening at around age 45. It used to be 50. They have lowered it.
Absolutely.
Yes. So, Dr. Cyril, some great advice here. African Americans do have a higher, anyone who has an African heritage does have an higher, increased risk, and they should consider screening sooner as well.
Yeah, true, absolutely true. Yeah.
Mm-hmm. Now, there's different types of screening options available. So I know there's like one where you can do a stool sample. There's also, did I see something recently where you can do blood work also?
So there are a lot of tests which I know what we are all trying to do is have a easy screening modality which is much more simpler, much more comfortable, and has a good sensitivity and specificity to detect colon polyps or cancer. So colonoscopy, like how we discussed, like the gold standard. Um, Before I go into different modalities of screening, one take home message: it's not the type of screening that you do, it is the fact that you are doing a screening that's most important, rather than not doing anything at all. Even if you do a stool test, even if you do a colonoscopy, even if you do a CT colonography, rather than going into which is best, which is if you do some form of a screening, that is what matters. Okay. So like I said, all the various societies puts it under different tiers. So colonoscopy, annual stool checking for blood traces, stool fit. Okay. Then there is something called as a multi-target DNA. Basically they test the tumor cells in the stool, okay, along with the blood. I believe the Cologuard is the name. You do that every 3 years. That is a stool-based test wherein they check for all these tumor cells in the polyp in the stool, and if any of them come positive, you do a colonoscopy. Okay, then we discussed about CT colonography that was to be done every 5 years. Then the other one is a sigmoidoscopy. Basically, what that means is you examine only your left side, but you're not examining the right side. That also every 5 years in the guidelines, it's there. But like one of my processes, it's like doing mammogram for only one of your breast and not checking the other breast. You're only looking at the left side. But definitely, it has shown some improvement. All these are different modalities for doing a colon cancer screening. And take home message: it's not you should do some form of a screening at least. If you want to do annually every year, check your stools for blood traces. That's fine. If any of them come positive, we will do a colonoscopy. That has shown to have reduced the incidence, definitely. But anyone with a family history, anyone who has an IBD, anyone who had polyps before, anyone who had colon cancer before, you do colonoscopy. That is right. Yeah.
All right, very good. Well, thank you so much for this very, very informative segment today. March, of course, being Colon Cancer Awareness Month. And you can now tell us, Shamari, all the details of, because I know every time it's breast cancer, colon cancer, HCCI, Health City Cayman Islands, really steps up to the plate and makes it super easy for people to take advantage of screening opportunities. So tell us a little bit about the screening specials.
Definitely. And Sandy, so as we said, if you meet the criteria, and 845 is the criteria, definitely you should be looking into getting a colonoscopy. And as March is Colon Cancer Awareness Month, we want to make sure that we make it as available as possible. And we're actually offering it at a reduced rate. But before I get into the reduced rate, if you want to be a part of the promotion, you go ahead and you call 640-4040 or info@healthcity.ky or through a Connect app. The actual consultation is free. And then based on the consultation, Dr. Cyril and team, and based on the insurance you have, it may be able to be covered without actually coming out of pocket. So just want to state that, if you come in, have the consultation, we'll figure out whether or not it's going to be covered by the insurance that you have. If not, the most you will pay is US $2,000 for the colonoscopy, which is actually below the actual cost of doing the procedure. But if you can't also afford the 2,000, we'll definitely work with you on a payment plan if your insurance doesn't cover it as well. So the appointments must be booked in March, and you'll take up the procedure prior to the end of April. And just also want to take the time to mention, and Sandy will have a specific program on it just because it's new. We have a sister company, which is called, One Health Cayman, which is our insurance product. And when we come back on to discuss One Health, we'll discuss the reason why we did it. But one of the main reasons is because we know through screening and diagnostics and the such, if you catch things early, the outcomes are better, right? And it also becomes less expensive because those major events that will happen in 5 to 10 years cost a lot more. So One Health Cayman actually includes the colonoscopy as part of all insurance packages. So whereas with some other insurance, you have to figure out how much wellness, whether or not it's covered, because we understand the need to have that type of diagnostics to ensure that you're healthy. Our One Health Cayman product includes it with no out-of-pocket to anyone. So eventually we'll come on and discuss where we are, what we're doing, the plans behind One Health. But just to mention that with that insurance product, colonoscopies will have no out-of-pocket cost to individuals. But that being said, anyone who wants to come in, you get your free consult with Dr. Alex. It doesn't have to be in person. It will be a teleconsult to start. And then depending on your insurance benefits, it may be covered. But if it isn't, the most you will pay is US $2,000, which is less than the actual cost to do the colonoscopy during this promotional time. Call us at 640-4040, info@healthcity.ky, or if you have the Connect app, you can go ahead and schedule your consult for this promotion as well.
All right, so inspiring, that should answer your question about the cost. And Nikki saying that she recently had an experience at Health City Cayman Islands, and it was amazing for and such a tiny island. I guess she was surprised. Has nothing but good things to say about her experience. And she said this focus on colon cancer is very timely and needed. Well done, Brad and Tim and Rebecca, for shining a light on this. So every Tuesday, normally, I know today's Thursday, but next week we'll be here on Thursday with Health City as well. They are here sharing a wealth of knowledge and information with their listeners. And thank you guys so much for doing that, because it saves lives. I've heard of people saying, Sandy, I saw this episode and decided to go get it done, and it really saved my life. So Dr. Cyril, thank you so much as always for imparting your knowledge and information. And Shamari, always here with us to give us some wonderful specials. Don't forget, you can make your appointments from now. They do get very, very busy. So are the colonoscopies going to be available at both locations, Shamari?
Go ahead, Dr. Cyril.
No, we will be doing most of our procedures at the new facility at Kamana Bay. Okay.
Oh,
and the HCCB primarily.
Oh, okay, nice. Wonderful. Yeah. So very, very convenient location, folks. So give them a call, book your appointment, and get in there. These are your little reminders. Every single March, get your appointments made to do your colonoscopy. That's the way to go. All right, folks. Thank you so much again to the Health City Cayman Islands team. Dr. Cyril joined us, and Shamari as well.
Thanks, Andy.
All right, guys. Have a good one.
Community Party is launching and you're invited. Join us Saturday, March 8th from 5 to 9 at Pedro St. James for an evening of community, connection, and conversation. Live music from Heat and Vashti Bodin. Fun for the kids and real talk with TCCP candidates. Plus local food and district booths.
The Caymanian Community Party is doing things differently. This isn't about speeches. It's about bringing people together, listening, and shaping a better future.
Admission is free, so bring the whole family. Learn more at Vote TCCP or follow us on social media. TCCP, enough is enough. The change starts now.
For the past 58 years, CUC has strived to be more than just an electricity provider. We have sought to be a foundational company. We give back to our community, and with the hard work and dedication of our employees, we have built and maintained one of the safest and most reliable electricity grids in the region. As we all look to the future, we at CUC want the Grand Cayman community to have confidence that our commitment to you will continue. Join us as we continue this journey together at empoweringcayman.com.